All right, everybody, and we're back. So we're going to talk about the rotator cuff. Yeah, Mr. Singletary, please.
Just letting you know I'm here. My camera's still not working.
No problem. Thank you, sir, for letting me know, though. Actually, I appreciate it. Sometimes I do check-ins, actually, to make sure everybody's here. But, oh, shoot. Bad teacher, but I want to grab the scapula from the next room because it's pretty darn important. So hold on 1 second, and I can't use my own because it's under my skin. So hold on. Sorry. I also decided I might need a hand. You never know. Okay. Let's see here. All right, so here's the scoop. You're going to hear the term there goes my arm. You're going to hear the term rotator cuff every day you're a massage therapist. At least once a week, but probably every day. Every day. It is the most commonly used term I've ever heard. And it's used to describe a whole lot of stuff in the shoulder. And when people have shoulder problems, they always say, "Oh, it's that's rotator cuff problems," and they're probably right. But rotator cuff can mean this whole slew of things, if you follow me. So let's remember the joint we're talking about. The rotator cuff talks about the true shoulder joint, which is your glenohumeral joint. Does anybody remember what type of joint the glenohumeral joint is? Yes, Miss Hendrickson, please.
I think it's a ball and socket joint.
It is a ball and socket joint. It's a ball and socket joint, and I can't take it off here really well, but we remember what the humerus looks like. It's got a head to it. That's the socket. Now, I don't know about you guys, but I don't see much of a hole there. My finger's not really going in something. It's a little teaspoon. So they call it a ball and socket because there is something that it rolls along, but that's not much of a socket. Whereas your hip joint, if I showed you your hip joint, it's a socket. Your hip goes in there, bone to bone. There's other stuff around there, but it actually fits in a hole. And I mean a real hole, a nice big deep hole you can put a golf ball in. That's your hip. It's called a ball and socket too. But this is more like a ball and a teaspoon. This is why people can dislocate their shoulders so easily, because there's not a lot here. Well, to give integrity to this area, there's a cuff around it. There is a cuff around it, and we call it the shoulder cuff, right? Or we call it the rotator cuff, because this thing rotates in here. So when somebody says, "Oh, I tore my rotator cuff," it could mean all of these things. It could mean there's a little lip around here of cartilage and fascia that makes this teaspoon a little bit bigger. And so quite often they mean that they've torn the little like labia, like the lip around this area that's made out of cartilage that helps to make more of a pocket in here. Not much more, but more of a pocket in here, and it's pretty easy to tear that too. That's one thing they could mean. They could mean that they tore any 4 of the rotator cuff muscles. And we're going to find out there's a muscle coming from all sides here, kind of around this area, that give integrity to the rotator joint, to the shoulder joint. So when somebody says, oh yeah, that's rotator cuff problems, it's a really generic thing. They might as well just say, you're having shoulder problems. It doesn't tell me a lot. What I really want to hear is, oh, I tore the lip that goes around, that area, or I tore a ligament that's tied to that area, or I tore the joint capsule in that area, or I tore one of the 4 rotator cuff muscles in that area. It could mean a whole lot of stuff. So I just wanted to frame our discussion first, that it's a very generic term thrown out when somebody's having shoulder problems. They're like, oh, rotator cuff problems. Okay. That's like me going in and saying, my knee hurts, and they go, oh yeah, knee problems. Yeah, that's what I said. So, the reason I'm also telling you this is clients will hear this from a doctor who sees shoulder problems all the time, and they don't want to cut into you right away, and they don't do anything. So if you go in and complain about your shoulder, they're like, take some Tylenol and do some stretches, and let's see if it doesn't get here's some anti-inflammatories. Let's see if it doesn't get better in a month. Sometimes it just gets better in a month, and I'm not even sure it has anything to do with anything the doctor did. It just healed, whatever it was. And they'll be like, it's just rotator cuff. And then the client comes to you and says, yeah, rotator cuff or torn rotator cuff or all this stuff. They don't know. Don't panic. You can probably still work on them and everything, because clients always tell you they've torn stuff, and they quite often have, but there's a big difference between a partial tear and a total tear. When you probably have I guarantee you've all partially torn muscles in your lifetime. Guarantee it without even knowing it. Total tears, because the muscle is actually so elastic, and so is the tendon, that like if you tore something here, you'd actually see it go down your arm and ball up underneath the skin. Like, it's really noticeable, and it gets black and blue, and it's heavy duty, and they have to actually take forceps in there and pull it back out and reattach it. That's a total tear. So if your client's walking around, they're not all black and blue, and they're like, yeah, I tore a rotator cuff muscle. Yeah, they can get massaged, don't worry. So anyway, it's a generic term that has a little bit of information in it, but we need to know more. Like, what did you tear, or what's wrong with the rotator cuff, or what's going on? And we're going to try to talk today about the muscles involved and some of the stuff that could be wrong, and how massage might help. And a great place, hopefully at the end of today's lecture too, Mr. Craven will have a great place to start. That's what we want to do, right? And the cool thing is, very unlikely you'll do any damage too, so it's worth kind of messing around in there and kind of seeing what you can do with massage. You're probably not going to make it worse. Okay, so that said, we know now that we have a ball and socket that has no socket. We know now there's all this soft tissue that helps make a little bit of a socket, and we know that there's these 4 muscles called the rotator cuff muscles that do rotate your shoulder, but they actually also are there just to give integrity to this ball and socket that doesn't have a socket. That's really the point. So, all right, and I'm just reaching down here because we might need this in a minute. All right, cool. I love this. All right. So let's do some backstory before I even show you a boring slideshow. Anybody know what bone this is? Miss Carrillo, please.
Got it from my scapula.
Miss Carrillo, you said you weren't picking stuff up. You are absolutely right. This is not a femur. It is not a humerus. It is a scapula, by golly. They're very identifiable. Could you, this is really hard. Can anybody tell me, is it the left or the right scapula? Yeah, Mr. Overman, please.
That would be, if I was sitting this way, the right? No, it's the left.
Yes, he's right, it's the left. He had to do exactly what I honestly was doing it with you, sir, because I was like, oh, I gotta know. If I slid this into my back, this is the side it makes sense on. You need to see the spine of the scapula back here. The coracoid process sticks out the front, so this is my left scapula. That's not important. We're just seeing if we can kind of orient stuff in 3D space. Mr. Jones, you have your hand raised.
I was just going to answer that.
Gotcha. Were you going to say left scapula?
I actually was going to say right.
You're too honest. I'd be like, of course I was going to say it. Don't do that right away.
What? It's because I did it so quickly. As soon as, once it paused a little bit, I realized this one.
Cool. Even better, actually. All right. Now Now remember, so this is how this thing is, right? Do we remember what this long thing here is called? Miss Rader, please.
The spine of the scapula.
Yes. Do we remember anybody what the indentation above the spine of the scapula is called? Mr. Overman, please.
So superior fossa of the spine of the scapula? Or
Pretty good.
Superior fossa.
Yes, supraspinous fossa. But you actually just said the same thing I said. If you said that to a doctor, they wouldn't think, they would be like, this guy knows his anatomy. It is the fossa superior to the spine of the scapula, or the supraspinous fossa. Well said, thank you. I actually prefer that over regurgitating information. Does anybody know what this is called down here? Miss Hendrickson, please.
The infraspinous fossa?
Yeah. And does anybody know what this is called underneath? This is actually the front of the scapula. We actually call it the anterior side of the scapula. But we also call it underneath because to us from the back, it's underneath. Anybody? Miss Carrillo, please. What's this part here?
Oh crap, I was holding it and then I was like, maybe I'm questioning
It is
myself.
not called oh crap.
No. Okay, so put it back up.
No, this is super up here. This is supraspinous fossa. This is infraspinous fossa.
I don't know what
This, okay. Miss Rader.
The subscapularis.
Yep. So, well, that's the muscle there. Subscapular fossa.
Subscapular fossa.
Yeah. So everybody, what you just told me in Latin was the cavity or the depression above the spine of the scapula, supraspinous fossa, the depression underneath the spine of the scapula, infraspinous fossa, infraspinatus, and the depression underneath the scapula, if you were working on me from the back, which is how you'd work on me probably, if you reached underneath, which happens to be the front of the scapula, but it's still, if you reach underneath, the subscapular fossa, the depression found underneath the scapula. This is very important because the muscles we're going to learn about today, 3 of them fit in these fossas, and they're named basically after them. So let's do that. If we take an arm, hold on here, everybody. If we take an arm, right, and I believe, let me just make sure, this is convenient because this happens to be the left arm. So, I'm going to, we always have to dissect people in massage, I'm going to rip off this huge muscle off here. What muscle am I taking off? Miss Rader, please.
Deltoid.
Deltoid. Yep, I'm taking off the whole deltoid. It's huge. When I do that, we expose this guy here. You can actually see back here the spine of the scapula. Okay? So, this muscle, this is one of your rotator cuff muscles, is called your supraspinatus. Its origin is the supraspinous fossa. The supraspinatus is in the supraspinous fossa. This muscle down here is the infraspinatus, the muscle found underneath the spine of the scapula, and it's in the infraspinous fossa. By the way, there's another little muscle here, right here, that you should not be able to tell the difference between this one and this one, basically. They should look like all these fibers kind of coming together. This is I'm not trying to flip you guys off, sorry. This is teres minor. Infraspinatus and teres minor are both rotator cuff muscles, and they go together. In a second, I'll explain why. And if I go underneath the scapula, this is actually how you'd be working on somebody when you guys are grabbing on their medial borders, and I pulled them open. This is the subscapularis, and it is in the subscapular fossa. All 4 of these muscles go over and grab on to the head of the humerus. This is what they do underneath the deltoids to help this really bad ball and socket you've got stay together. Yes, they move your humerus around. That's why they're called rotator muscles. But their job really is mainly to give integrity to this joint. So they all start on the scapula and they all end up on the humerus. 3 of them end up on the greater tubercle of the humerus. Anyway, they all go over there. So from back here, they come around and grab on. This one, by the way, goes underneath your acromion process and grabs on up here, and that's very important. And I'll show you what I mean by that. Miss Carrillo, please.
Hi, it's gonna sound silly, but when you said integrity, are you meaning like to stabilize it? Or?
Yes, that doesn't sound silly. Thank you for helping clarify what I'm saying. Yes. Integrity meaning make it stronger, make it have more integrity. But I don't mean emotional integrity. I mean like, yes, you're right. Make it stronger, stabilize it. Yes. Help put bands around something that doesn't have much to keep it in place. Yeah, that's exactly what I mean. Well said. So, to be really clear, if we look at this guy, this is the acromion process here. The supraspinatus actually goes underneath it. That's my finger pointing out there, and actually attaches to the head of the humerus, not the head, the greater tubercle of the humerus right here. It actually goes underneath the acromion process and comes over to here. So you can touch it here, but then it goes underneath a little bridge and gets over here. And you're going to see that in the slides, but I just wanted to kind of show you on Mr. Skeleton here. It goes underneath. Really, this is my finger right here, is the supraspinatus right now, kind of. And if you see, it goes all the way underneath here to get over to this guy out here. Can we see that? And when you're palpating somebody, you can feel it here. You obviously can't feel it underneath the acromion process, but when you're hitting the acromion process, if we drilled down underneath there, you'd find the supraspinatus too, and it goes all the way out to the shoulder to help hold the shoulder in place. That's the supraspinatus. And that's important that it goes underneath the acromion process, and we'll get to why here in a second. Now I want to share, now that we've got kind of an overview, now I'll show you some two-dimensional pictures to see how that goes. So let's do that. Here we go, everybody. Let me, my window, there we go. Okay. Should be coming up right now. Okay. By the way, note that you can actually see the spine, the scapula, the acromion process, and starting to go in the clavicle here. Okay, so this is what I just told you guys. I said, hey, this is looking from the back of a body. So we are looking at the posterior side of somebody's back, the side you normally massage. The side you normally massage. Which is why we can see the spine of the scapula right here, right? And we're going to talk about the first of the 4 rotator cuff muscles, in some ways possibly the most important one in the sense of the one that gives you a lot of trouble on people, and that's the supraspinatus. Its origin is in the supraspinous fossa. It starts here, it's glued here. You can rub it here, you should be rubbing it here. So when you're doing somebody's traps, you also want to kind of push through the traps right above the spine of the scapula and get in there. That's super important. Ms. Hendrickson, please.
What does the N mean down below the eye?
Nervation. It means the nerve that comes from your brain down your spine comes out around C4, C5, and C6 and shoots out the side of your spine and goes to feed this muscle.
Okay.
So if you would never do this, but if I were to like cut into next to your C4, C5, C6, I mean, lots of really bad things would happen, but one of the bad things would happen is you wouldn't be able to use your supraspinatus anymore. It's where it gets its motor function from, its messages from the brain. But you don't even need to memorize that because you already know that Tapscott said nerves coming from the neck feed the arm. And this is the arm. Yeah. And that's why I don't get really into the nervation. I mean, I really care about nervation, but I don't care that you memorize C4, C5, C6 because you're going to rub the neck if you think there's problems with the arm. You're going to rub the arm too, but you're going to rub the neck just in case. So This guy goes underneath the acromion process and hooks onto a big bump, the biggest bump actually, on the lateral side of the humerus called the greater tubercle. Mr. Craven, please.
Yeah, so does it actually like originate from like the actual like fossa, so like the big bony part, or is it actually attaching to like the medial edge?
I love that question, by the way. I love that question. No, it's not attaching to a point. It's probably glued into the whole thing. Like you and I would have to go in there. We wouldn't be able to just cut one little thing and pull it off. We'd actually probably have to scrape it out of the fossa.
Like you wouldn't be able to get under it, like.
No, you would not be able to get under it. Yeah. No, you're right. And by the way, there are some muscles, you're right, like your bicep. In theory, I could go snip it in two places on two ends and we'd just take your bicep off, right? By the way, there's some fascia that would get in our way. But we could really just take your bicep out. It'd be disgusting. But we could do it. This thing, you could snip it on both ends and we'd still be like, darn, it's glued in there. We wouldn't be able to get underneath it. We'd have to kind of scrape it out with like a grapefruit spoon, which is really disgusting too. All right, sorry. That's why I'm not a serial killer. Mr. Singletary, you have your hand raised.
Okay, so is that the part that's actually doing the moving in that section? Why it's called the insertion?
Yes. So absolutely. So that's exactly right. I'm playing with my arm while you're talking. So yeah. So what would happen? This is what's so cool about. Don't worry about the slide for a second. If I'm not going to go underneath the acromion process, it's too hard to get my finger under there. But if my finger comes out here and it shortens, what's going to happen to the glenohumeral joint? What movement is this? Mr. Singletary. What movement?
You're moving away from the trunk of the body, so you're abducting.
Yes! Thank you, sir. Yes. And you are abducting. And you can actually see me do it. I just can't pull hard enough to get this thing to keep going. But I am abducting with this thing. Yeah. Yeah. Mr. Craven, please.
I think I'm having like a little bit of moment of clarity right now. So like, I remember you mentioning before, like, as far as like the movement goes, like when you're placing your finger on top of your shoulder, like you're not able to go over like a certain distance, like adducted, because like it's attached to the bone, so it really can't like contract a whole lot, right? Like it really, there's not a whole lot it can do.
I mean, I think you're on the right track, but I want to make sure that you're saying it can't go up higher because of just how little it can do, kind of thing?
Like there's no, if it's attached to like, it almost seems like it has like two origins almost, right? Like it's attached throughout like the whole bone, whereas like a lot of these muscles like are attached like at one spot, and like the bulk of them are kind of like free to move.
Yeah, I get what you're saying, and actually it's very insightful. I think you're incorrect though. Darn. But I like what you're saying. You're hitting on a really interesting point, which is even though muscles can only contract, believe it or not, they contract very little. And they get a lot of movement out of that contraction. And here's what I mean by that. All of the joints in your body are set up like this one right here, where the muscle is attached to this end, not this end. And if I'm attached to this end, I don't have to pull very much to get that pen to go way up high. My finger went down about maybe a centimeter here, and I got this pen to go up 10 centimeters. And so all of your muscles in your body, even your biceps, sir, which have a lot more movement, I know what you mean, but they don't contract very much. The reason that your shoulder doesn't go out further, which is going to be helpful to your mom's situation, is that literally the humerus hits the acromion process here. Yeah. So if I can get it to go up higher by breaking your joint open. like it's really yeah. But that's what's stopping it there. But your logic was right. Like I see where you're going with it. Miss Green, please.
Sorry, this is like a basic question, but
There's no such thing.
where has the letters, like I know the A is like for action, the O for origin, I for insertion, but what's N? Like I'm like been wondering that for a minute. I feel like
Somebody just asked me that question. Was it Miss Hendrickson?
sorry.
Yes. No, no, I didn't. Sorry, I wasn't scolding you. I'm just saying, like somebody just asked me, Miss Hendrickson, what is the N for?
It's the nervation, where the nerve comes from that feeds that muscle.
Got it. Okay, thank you.
So-
I was like wondering, and I kept thinking to myself, watch somebody probably ask that question, but I'll ask it anyway.
Yeah.
Yeah, when I was doing my homework, I was like, is this important? I don't know.
So what it means, everybody, just so we're clear, your brain sends all the signals to your body down your spine, and those signals have to come out of the spine at certain places to get your arms and legs. And at C, what that C4, 5, and 6 means is 1, 2, 3, 4. So right through here, here, and here, these nerves come out to go to this muscle. That's what it means. And it means, Miss Green, if I don't know, took some type of knife or something and cut this here, you wouldn't be able to use this muscle right here.
Okay.
Yeah.
Got it.
But you don't have to memorize that, Miss Green.
Okay. Thank you. I was
But hold
just
on.
curious.
The reason you don't have to memorize it is because the nerves from your neck feed your arms. That's all you gotta
Okay.
remember. Yeah.
Okay, got it.
Thank you, ma'am.
Nerves from your neck feed your
Feed
arm.
your arm. Yes.
Thank
Yes. Okay. So supraspinatus goes under here, and it abducts, as Mr. Singletary told us. And he didn't tell us because he read it from the book. He told us because he looked at the little thing and went, oh, that's what it would do. It abducts the shoulder. It can't go past here because the humerus actually runs into the acromion process. So this creates some intrinsic problems, and this is one of the most common problems in a rotator cuff situation if there's not a tear. And that is, what muscle gets pinched possibly when the arm comes up like this? Yes, Miss Carrillo, please.
Is that the supraspinatus?
The supraspinatus can actually get pinched there. And what happens, by the way, when you guys feel pain? When you feel pain, you just kind of relax, let it go, like, or do you, Miss Hendrickson, please.
Usually tense up or pull back.
Okay, so think about this for a second. This muscle does go underneath. Let me stop sharing here just for a second, just so we can see this. By the way, you can have lots of other problems with the rotator cuff stuff. You can have tears and stuff, but this one's common, and there's stuff you can do with the massage to make it better. So, if this guy is going underneath here, and its job is to lift this up, right? Think about this too. Look, I'm pulling down the shoulder right now. Part of what the supraspinatus does too when it contracts is just kind of keeps this thing in its socket, right? It helps lift it up here, right? Well, if it's really tight, it really lifts it up here. It actually pinches itself if it gets tight. So the problem is when it gets hurt and it tenses up, it pinches itself more, which causes it more pain, which causes it to tense up more, which causes it to pull your shoulder tighter, which causes it to pinch more, which causes it to hurt more, which causes it to tighten up more, which causes it to pinch itself more, which causes it to tighten up more, which causes it to hurt more. Please somebody stop me. We call that a pain cycle. You do it in lots of places in your body, but that's just one of the best examples I can think of, right? So it's a pain cycle, and it's causing that thing. And a lot of people that have this problem can't lift their shoulder out to the side of their body pain-free. They feel a popping in here that's painful. They feel some, that's where the pain goes. And that is quite often because that area is getting irritated. There's probably swelling in there that's rubbing on it, all sorts of stuff, and it's making it worse and worse and worse. And one of the things I actually do for this, believe it or not, is this is an aggressive move, by the way, but I actually take my thumb here and kind of try to wiggle it in. I use the arm like this, and I try to wiggle it in between your acromion process and your shoulder. I'm actually trying to do this. I'm trying to open it back up. I can't do this, but I'd love to get my thumb in there. I'm trying to pop your shoulder out of socket, but I don't really want to pop it out of socket. I'm trying to open up the socket. I want to stretch that back out. And I can do that by lifting your arm for you because I want your deltoid relaxed. If you tense up your deltoid, there's no way I'm going to get through it. And I sink down through it, and I push down this area, And I'll do this, and I'll do it all the way around, by the way, just to open up the whole joint and start to open up that area. By the way, before I did any of that, I would have loosened up the deltoids and everything. But it's a great example of a very common problem that massage can help in the rotator cuff area. And obviously, by the way, rotator cuffs get tight just in general, so all the other muscles can be culprits too. But that's a really interesting one because it can kind of pinch itself and create what we call a pain cycle. Where the actual pain, like if I have a pinched nerve in my bicep's tightening up. Every time it tightens up, it pinches the nerve more, which makes me tighten my bicep up more unconsciously. And that, you know, all that kind of stuff. But we are often trying to just undo pain cycles in the body. Let's reshare. Boom, boom, boom. Do, do, do. Okay. So that's supraspinatus. Super easy to remember, by the way. No pun intended, actually. It's super easy to remember. It has got an origin in the supraspinous fossa and it attaches to the greater tubercle of the humerus, which is on the outside of my humerus. Makes sense. It's got a pull out there. 3 of your 4 rotator cuff muscles, by the way, attach to the greater tubercle, which makes sense because they want to hold that into the body. They want to hold this whole joint together. So let's look at the infraspinatus and teres minor. Anytime I say infraspinatus, you say teres minor. And anytime I say teres minor, you say infraspinatus. They do the same thing, and they almost might as well be the same thing. From a massage therapist point of view, you can't tell me which one of these is the infraspinatus and which one is the teres major from teres minor from touch. Yes, Ms. Dimitrik.
Just quick question. When it's attached to the supraspinatus fossa, is it attached all over that bone or just on the medial region or?
Yeah, Mr. Craven and I were discussing this too. It is attached all over that bone. So to answer your question, you couldn't just cut it out of, like, you couldn't just snip one end and kind of take it off. It is glued to the fossa itself. Yes. Does that help? Is that what you meant? Yeah. Yeah, it would be very difficult to get it out of there. Yes. Mr. Overman, please.
I find the origin of words really helps me, so I'm curious with the teres minor and major, both of them mimic another muscle, like basically identically. So does teres have anything to do with that, do you know?
I should know. As your teacher, I should know, but I actually don't know. Origins of teres.
I was just curious.
No, I'm curious too. Hold on. Teres muscle. Oh, it's tell me origins. Hold on. I just put it to origins. Tell me origin insertion. I don't want that. Oh, it means rounded. So no. And by the way, they probably found them and named them before they knew what they did. And they found 2 there, and they were kind of on the side of the scapula, and so they said, oh, there's these 2 rounded muscles. One's on top of the other, one's bigger than the other. We're going to call the bigger one teres major and the smaller one teres minor, and they do opposite things, by the way. So beyond their names, they do opposite things completely. Teres minor goes with infraspinatus. Teres major goes with latissimus dorsi. Basically 100% of the time. And the way I remember that, teres major big, latissimus dorsi big. Teres minor small, infraspinatus small. Yeah. Okay, so let's go to the next slide. Boom. This is the infraspinatus. Now, it's on the back of the scapula, right? It goes across and grabs onto the head of the humerus, like my hand here, if you can see that. If my hand contracts, what kind of rotation does this give us? When you start rotating to the outside or the back, what do we call that? Miss Rader, please.
Lateral rotation.
She's 100% right. Lateral rotation. Now, by the way, it can also adduct. It can help pull the arm in a little bit, but lateral rotation is the most important thing to remember. That's why it's called a rotator cuff muscle. It helps with rotations. I know supraspinatus is a rotator cuff muscle. It doesn't help with rotations, but it does help stabilize the rotator cuff. Anyway, it's right here, and it goes, shoop, and it rotates that thing out. Yes, Miss Clayton, please.
Is that retraction too or not?
No. I know why you're saying that. Retraction would be if the scapula moved. This is the bone moving in this joint. So, and this is very confusing, but very important to kind of understand. The scapulothoracic joint and the glenohumeral joint are like a crane that's got wheels. And here's what I mean by that. A crane, if you can kind of see my arm here, the crane is like the glenohumeral joint. It can move around, right, and pick stuff up, right? The wheels are the scapulothoracic joint that can move the whole crane to another location. That's because you're on twice, Miss Clayton, that's why. But so the scapulothoracic joint can protract or retract, and the glenohumeral joint can still do all that stuff from a new location. That's why I can get all those movements out of my body. My scapulothoracic joint carries my glenohumeral joint around, moves it up around it, and then my glenohumeral joint can decide to do stuff when it gets there, or before. But my point is, they work together. That's why you get so much movement out of a shoulder. It's absolutely unbelievable because it's like a crane on wheels. It's got all the cool movements that a crane does. That's your glenohumeral joint, ball and socket here, right? But you can move the whole crane. I can protract it, retract it, elevate it, depress it, and still do all that stuff. Does that make sense? Kind of? Sort of?
Yes,
I hope. Good.
That was helpful.
Good. Cool. Okay. So, lo and behold, this is going to shock us all. But the infraspinatus actually has an origin in the infraspinous fossa, right? And by the way, back when we were talking about this, I should have said this. I apologize. This darkened in area is the actual origin, meaning it's actually where the meat of the muscle is attached. So for those of you that asked, like, oh, is it just attached in a part? I should have pointed that out right away. I apologize. It's attached to here. The supraspinatus is attached to here. The infraspinatus is attached to here. And the teres minor is attached to here. The teres minor would be easier to cut off. And these are the insertions. The supraspinatus comes across and inserts right there. The infraspinatus comes over and inserts right here. And the teres minor comes over and inserts right here. All on various locations of the greater tubercle of the humerus. So look at the infraspinatus here. It helps with a lateral rotation. Here's the teres minor. It helps with the lateral rotation and adduct and stabilize. Infraspinatus helps with the lateral rotation, adduct and stabilize. Teres minor helps with lateral rotation, adduct and stabilize. Lateral rotation, lateral rotation. And when you are massaging somebody, let's see if they have a full picture here. Hold on. No, come on, people. Give me a full picture. Shoot. I'll just show you a full picture. Hold on. Again, with our little thing here. This is the teres minor, and this is the infraspinatus. But when you're rubbing somebody, if you think you can tell the difference between these two, you're a better therapist than me. To me, they're a unit. They do the same thing. They go to the same place. They're the same thing. And that's why I say they're in the same place. They look like the same thing. Yes, when we dig deep down inside, we can find they're in slightly different locations and such. I'm not saying it's not important to know that. But you can treat them the same. If somebody's having a problem with lateral rotation, you would look at both these muscles. They probably work together almost all the time. They have the same actions, essentially the same location, and they're coupled. Yes, they are coupled. They're a couple. They're going to the prom together, but not only that, they're going to get married. All right? And they're following the lead of the latissimus dorsi and the teres major, who are already married. They're a couple too. Okay? Cool. So, teres minor right here, it attaches to the lateral border of the scapula, so this helps to make up your axillary region, your posterior border of your armpit, your axillary region. is made up partially of this muscle. By the way, below this muscle would be the teres major. But anyway, axillary region of the posterior border of the axillary region, and it's right here. But it does the exact same thing as the infraspinatus. Goes just to a slightly different spot. Cool. They both help with lateral rotation. Yes, Miss Clayton, please.
Wouldn't the minor help like lift your back more on an angle, like a tilt? Like if that's gone and it didn't exist, it seems like you would have a hard time raising your shoulder kind of diagonally in the back.
No. So I think about this, Miss Clayton. Can you see the skeleton in me right now?
Yeah.
Let me stop sharing here. I like that you're thinking. I like that you're thinking three-dimensionally about pulling. This muscle's down here, right? Essentially.
Yeah.
This is kind of teres minor. It's teres major too. Teres minor down here, right? If it contracts, it's going to adduct, right?
Mhm.
So I don't know what you mean about pulling. What do you mean pulling down the?
So if you put your arm directly behind you, if you what's it called? Protract? No. Like you swing your arm backward.
Maybe like an
And
extension?
Yeah, if you extend your arm and then you bring it toward your spine and up. Yeah.
So you are describing, just so we're clear, you're describing this movement.
Yes.
Oh, okay. I've never thought about it. Okay, I love it. So I've never thought about this. Let's do it together. So but let's call it what it is. I am extending, and then believe it or not, even though I'm coming towards my midline, we're still going to call this an abduction because we're coming all the way from in front, all the way back here. So I am extending and abducting, okay?
Mhm.
Possibly in a wrestling move or being arrested, okay?
Right.
And what would it help me do or wouldn't help me do?
Get your arm now superior.
Up?
Yes.
Okay, so to lift an arm up, I've got to be above it. This muscle's down here,
Oh, okay.
right?
Never mind.
No, don't. I love that you're thinking this way, but just remember that. Like, if I want, muscles can only contract or pull or whatever, and so there is no way, for example, I'm in front of the skeleton, there's no way for me to have anything happen behind it. I can do stuff. If I'm a muscle up here, I can pull it this way. I can pull stuff over this. But if I want to get back there, I got to get all the way over here and get back here. And if I want to get the stuff to go up, I've got to be on top. If I want to get stuff to go down, I got to be on the bottom. Does that make sense?
Okay. Yeah.
Good. Cool. Don't worry about the accuracy of your questions or your thoughts. This is the exact type of thinking that you use to solve problems as a massage therapist. This is exactly what I feel like schools don't do. So this is the type of thinking I want you guys to be doing. This is great. Anyway, so, and I've never thought about an arm doing that. Thank you. So we've got, let me continue sharing here really quick. So we just talked about the teres minor. I'm sorry, I keep saying that. Teres minor and infraspinatus. Teres minor and infraspinatus. They're both tiny. They both do lateral rotations. They both help a little bit with adduction. All these muscles help with shoulder stability, shoulder integrity, holding your shoulder together. Let's look underneath the scapula. Subscapularis. Look, this too attaches to the entire fossa, the subscapular fossa. It goes in front and attaches to the lesser tubercle of the humerus. You can see all the fibers here. So because it does that, it does a medial rotation. Now, let's look at why. Here we are. This muscle, remember this guy? Left scapula. This muscle's on the inside here. It's like my hand. And it reaches around kind of like this. What happens if I'm on the inside here and I reach around and I start to pull? What kind of rotation do we get? Miss Carrillo, please.
Medially?
Yes, she's right. Yeah. Miss Carrillo, can you name 2 other muscles that we have learned fairly recently that can also medially rotate because they reach, I know it's so mean. She's like, I knew that answer, now you want me, because they reach under like Tapscott's doing right now. The subscapularis might grab onto here. These other 2, by the way, grab on, one grabs onto the intertrabecular groove, the other one grabs onto the crest over here, but they grab on and they too help medially rotate. Do you know what those are, Miss Carrillo?
I got a brain fart, I'm sorry.
That's okay. Don't ever apologize. Don't ever apologize in this class. Mr. Singletary.
Is it the latissimus dorsi and the teres major?
Yeah. They too, remember, they're very weird. They come up underneath here and grab on. And remember, Miss Carrillo, when I ran out there and I jumped on your thing and I grabbed behind your shirt and you're like, what is this guy doing? In a way, the subscapularis does that, but it only does it from your scapula. But anyway, so now what we've got, everybody, is we've got, 1 second, sir. We've got, if this is my humerus here, I've got in back here, I've got the teres minor and infraspinatus here. In the front, I've got the subscapularis here. And on top, I've got the supraspinatus. And what do? They hold my shoulder in place. That's why they give integrity. They give integrity to the shoulder. That's what they do. Mr. Craven, please. Too close.
I think I'm a little bit confused.
Good, me too.
The lateral and medial rotation, because I feel like whichever way you go, eventually it's going to be going medially or like laterally, like because it's a full circle, right? Like,
Actually, you're brilliant, sir. Thank you. You are absolutely right. If I am here, no matter which way I rotate, I'm rotating medially. I hope I'm not screwing everybody up. Please don't I'm just having a discussion with theoretically here. You are absolutely right. I am rolling in either way, but we don't talk that way. Because we talk as though we are looking at somebody from the front in anatomical position. And from the front, it looks like I'm rolling in medially, and from here, it looks like I'm rolling out laterally. But sir, you are dead on right in reality. But it's almost like we have to we have to establish something so that we can use common terms kind of thing. You're absolutely right. But you're absolutely right. And so you just have, that's why some people call it like, even that, you're just right. So, yeah. When it rolls to the front, it's a medial one. When it rolls to the back, it's a lateral one. And we probably really should call them an anterior or posterior rotation. I've never heard anybody call it that way, but actually from what you just said, first time in my life, I would actually, if I could change the book, I would do that. Really. Thank you. Ms. Carrillo, please.
It actually, because the same thing that Mr. Craven said always confused me, but what helped me remember that maybe we should be looking at it anatomically is when he helped Mr. Jones with the test question, and it was something about one of the muscles facing forward and said, I think maybe it was this, maybe I don't remember, it was a couple of weeks back, but when you explained, okay, so but this is facing this way, and he's like, oh, okay, I get it. But that's the reason why I started thinking maybe they're talking anatomical position when they're talking about the rotates. It's a brain mess.
It is. Well, all this stuff is a lot. And I would comment on the specific thing with Mr. Jones, but I don't remember what happened yesterday. So forget about last week. That's no past. Ms. Hendrickson.
Yeah, it's not really related, but it kind of made me think of like in math when you're learning PEMDAS, like you have a certain rules to follow in the right order of how you solve an equation, like if there's parentheses
Oh,
or
yeah.
components, stuff like that. So, because if you have the same equation, and you do it out of order, you're going to get a completely different answer. So
Sure.
it's kind of like that.
Yeah, no, I get what you're saying. Yeah. And so, again, we make some pretend stuff, and we say, hey, we're going to pretend this person's in anatomical position, even if they're not, because up here, guess what? This is a medial rotation. And we do that, by the way, everybody, because of my crane example. We say, hey, we're going to pretend like the crane platform's here all the time so that we can discuss this movement in relation to the crane. But we know sometimes the crane's over here and up here and all that other stuff. But we're going to put it back here so that we can discuss these things.
So it's kind of like the anatomical position is like 0. It's like
Yes, it is. It's like 0. Exactly. And in a way, it's not completely true, but in a way, what's happening in my glenohumeral joint is the same here as it is here. It's my scapula that moved that makes this look different. I'm doing medial and lateral rotations in all of these. And the same thing is happening in my joint. It's my scapula that's moving around right now. I mean, my glenohumeral joint was moving for all those too, but my scapula was traveling, yes. Mr. Singletary.
Would you say that a lateral movement is moving away, abduction, and medial is adduction?
No. I mean, by the way, sir, your logic makes sense in my brain, what you're saying, but I think it's going to confuse us terribly. So, abductions and adductions move away from the midline. Medial and lateral rotations don't move away or close to the midline. They rotate. This is kind of what Mr. Craven was saying. He's like, hey, they don't really go anywhere, so why do we call them medial or lateral? They really should be called front and back. But anyway, they don't move away. They're just twisting right here. Like my hand's not moving away from my body right now. Or to it. It's just rotating. So we're trying to describe rotations, and rotations are a bear. It was kind of like the scapula. We're like, what's it doing here? You guys would all say upward rotation now because we picked this acromion process. But if I would have told you it was the superior angle of the scapula, guess what? Superior angle of the scapula goes down on an upward rotation.
Right, okay.
So we all said, hey, not just us, by the way, the entire medical community, said, hey, that's what we're going to call, that's what we're going to look at. That thing goes up, we call it an upward rotation, even though we know there's no such thing as an upward rotation or downward rotation. There's only rotations. There's just rotations, right? Just like this medial and lateral thing, it's almost like we said, okay, looks like you're rolling in, so we'll call it medial. But it's not true. It's just rolling, yes. Wow. Good. These are really good thought processes, everybody. Really, really good thought processes. Okay, so we got 4 rotator cuff muscles, right? Everybody else still with us, by the way? Mr. Thornton, are you there? I always like picking on you. Making sure. Mr. Jones is there, yes. Mr. Thornton, are you there, sir?
No, sorry, I was in the restroom.
No. I just called on you just this second. I can just call on you to say, sir, can you tell me what the name of the 4 rotator cuff muscles are? We're doing a little review here. Supraspinatus, yes.
Yeah, infraspinatus.
Yes.
Minor and supras.
Sub.
Or subs. I don't know.
Subscapularis.
Subscapularis.
Yeah. Hold on one second, everybody. This is our laundry guy. Just gotta make sure he knows not to come today. Hey, Renee. Oh, all right. I thought you weren't coming till next week, but that's fine. We've got a little bit of laundry. Unless, by the way, Renee, unless you want to wait till next week, it's your call. We don't have a lot. Like a bag, like one bag. Yeah. All right, we definitely will have more next week, and thank you, sir. All right, bye-bye. Guys, I'm sorry, that's very unprofessional. It's just that we're a little stretched right now. And we have to have laundry service start up here. And the guy's never found the place before. Okay, so The 4 rotator cuff muscles are supraspinatus, infraspinatus, teres minor, and subscapularis. Thank you, Mr. Thornton, by the way. Mr. Bose.
Okay.
You know what I'm going to ask you. What are the 4 rotator cuff muscles?
Subscapularis.
Yep.
Infraspinatus.
Yes. No, you're saying it.
Supraspinatus.
Yes, ma'am. And?
Teres minor.
Yes. Yeah. And that was 100% correct what she said. I, by the way, for your guys' like memory, I would always say teres minor and infraspinatus together. So once you say one, say the other. But that was perfectly 100% true. Thank you, Mr. Bose. Miss Everson.
Hello.
Hello. Hey, what are the 4 rotator cuff muscles?
There's the teres minor, the infraspinatus, the
Yeah.
and then
Wait, supraspinatus, but we didn't finish subscapularis. Guys, it really is like a Harry Potter movie, right? Subscapularis, infraspinatus. You know, awesome. Thank you, Miss Everson. That's beautiful. Mr. Manzanares.
Yeah.
Mr. Manzanares, what are the 4 rotator cuff muscles, sir?
The supraspinatus, the subscapularis,
Subscapularis. Good.
and I forgot the other.
The 2 that go together. The one.
Teres major,
Teres minor.
minor, and the major, or
No. Teres minor and the infraspinatus.
infraspinatus.
Yeah. So let's do them again just to make sure they're in your head the right way. You know what I mean? So the one above the spine of the scapula you said was
Supraspinatus,
Yes.
and the other one, the subscapularis,
Subscapularis. Yes.
and the teres minor,
Yes.
and the infraspinatus.
Infraspinatus. But that was excellent. Thank you, sir. Thank you. That was good. I like it. That was good. Miss Eversole.
Yes, sir.
Ma'am. How nice. Yes, sir. Ma'am, which of the 4 rotator cuff muscles could abduct my shoulder?
Oh gosh.
Yeah. I can give you a clue that's really, really helpful and will help you for the rest of your life.
Okay.
If you had to lift my arm up, would you be in front of it, behind it, underneath it, or on top of it? If you had to lift it up.
Trying to lift your arm up?
If you had to just lift it up, if all you could do is pull, and you had to get my arm up, would you be behind it, in front of it, underneath it, or on top of it?
I think on top of it?
Yeah, I don't know how, by the way, I've never lifted anything from, let me try to lift from underneath. Well, okay, I can only pull, let me think. If I can only pull, okay, cool. So what would be the one that's up? Is there one that kind of sounds like up?
Is it the supraspinatus?
That's it! Oh my God, thank you. That's awesome. Supraspinatus is on top, so it lifts up. And we call that an abduction, but it lifts up. Yeah, very cool. Really well done. Thank you. Miss Abelos.
Yes.
Miss Abelos, what is the rotator cuff muscle that can cause me to do a medial rotation?
Your subscapularis.
She's right, and thank you, 100% right, and beautiful and perfect. And by the way, Mr. Craven, this is kind of to your point, which is kind of neat. The subscapularis is on the anterior side of the scapula, and it rolls me to the front. We call that a medial rotation, but it's in front, it can only pull, so it rolls me to the front. I wonder what the 2 rotator cuff muscles in back do.
Me?
Go ahead, Miss Avalos, please. You're on fire.
the back muscles, they laterally rotate.
Exactly. Beautifully done. Because they're behind me. You couldn't pull my arms back behind me unless you're behind me. You could push them, but you can't pull them. You got to be behind me. Well done. Thank you, thank you, thank you. Thank you. Miss Green. Thought I saw you there for a second. Are you there?
Yes.
Miss Green, what are the 4 rotator cuff muscles, madam?
Supraspinatus, teres minor, infraspinatus, and subscapularis.
You make it look easy, Miss Green. Thank you. Thank you. You didn't even try. You're just like, whatever. I know those. All right. So, let's move it right along. We're basically done here, everybody, so bear with me. By the way, all 4 of these muscles are palpatable, right? The super, we're looking down on this guy from heaven. The super, oh yes, Miss Everson, please. Miss Everson, was that an accident?
Right. How is the subscapularis palpable?
How's it palpatable? She's right, by the way. It's the hardest one to get to, but it is palpatable. You go, it's on the inside of somebody's axillary region. So if my arm is laying down like this, and you push in, not into my armpit like this, but to the back border, you're pushing on the back side, you're pushing on the front of my scapula. And that's how it's palpatable. Like, you can push on the front of somebody, when somebody's arms out like this, you can push in their on the front side of their scapula. I keep saying the back, but you know what I mean. So you can actually do this. Like, this is where it is right now, basically. And you can push on it. You can actually rub it there. I recommend putting a sheet over it first. I don't rub it directly, and the sheet is not because it's gross in there or anything like that. I put the sheet there because people are really ticklish or really sensitive. We don't have people wiggling around our armpits very often. And again, I want to be very clear what I mean by in there. I don't mean, everybody, just so we're clear, I don't mean that I go into their armpit. I'm going into their scapula back here. And on this skeleton's got the scapula glued down, but your scapula's come out. You can push on the back. You can do it to yourselves right now. If you push back here, you are pushing, you got to push posteriorly. If you push medially, you're going into your armpit. If you push posteriorly, you're pushing on your posterior border of your scapula. You're also going to hit your lats and all sorts of other stuff, but it's back there. I hope that helps. And Miss Everson, I'm happy to come into the lab and poke on yours.
So palpate means that you could just touch the muscle?
Thank you. Yeah. Yeah, I should define that better, but palpate means, yes, you can touch it. And obviously we can't truly palpate anything. It means you can feel it underneath the surface. So, so the supraspinatus here on top, you have to go through the trapezius, everybody, but you can feel it. You can find the spine of the scapula and you can push in and you can find this depression here and you can rub it. You can find the spine of the scapula and go underneath it and you can rub the infraspinatus and teres minor. You can go under the axillary region and you can actually hit the subscapularis. This area is sensitive, that's why I put a sheet over it and then rub in there. Mr. Richards, please.
Is that easier in a prone position? Because when I was watching the video, he put his arm down the side and he was able to get underneath.
Oh. Yeah, I've always done it in a supine position. But there's more than one way to skin a scapula. But I'm sure you could. Yeah. Yeah, you should play with it in the lab. Again, though, I would use a sheet because it's a sensitive area. And for some reason, the sheet, it was just a trick a massage therapist showed me once. A sheet, for some reason, takes a lot of the sensitivity away. I don't know why. But anyway, try it both. But I'm used to doing it with them supine on their spine, and I've got them laying down here, and I put a sheet over my hand, and I come in this way. For the subscapularis. Yeah. You should try it both ways, though. I like that idea. Mr. Craven, please.
Did you kind of, like, pull Mr. Richards up by it, like, a little bit? Like,
right.
Kind of, maybe, like, the edge of it?
Yeah. So you're absolutely right. When you grab onto the medial border, you're going through a whole bunch of muscles, but when I grab on, I am grabbing on to part of the subscapularis underneath. You're absolutely right. I'm hitting it from that side. We're talking about attacking it from the lateral border, but you are 100% right, you would do both. And that, by the way, is why I love that move. Because when I grab onto his scapula, I'm doing 13 things at once. And anybody, you all could do massage before you ever showed up here. You've all rubbed somebody, done something, you could do massage before you showed up here. But hopefully, I hope this is true, may not be true, some of you are quite good. Hopefully, what would take you 4 hours to get done when you showed up day one, I could get done in 4 minutes, right? Hopefully I'm more accurate, I'm getting more done faster. So as you guys get better and better at massage, you find moves that can attack more spots, more accurately, more quickly, and you're wasting less time and you're missing less things. That's what we're really trying to do here. Anybody can rub, right? We're trying to become better at it and find better and better moves. And as you get better in the course, by the way, you'll have stuff that actually works. You'll be like, this is a good move. You'll find something that works better and it'll be like, I don't use that anymore because it's time consuming and I've got something better. And time consuming matters because the more I can pack in to your hour or 2 hours, the better the massage is, right? I mean, a three-year-old can accomplish what any of us can accomplish right now if we give them enough time. They will accidentally walk on that spot eventually. They will accidentally throw a toy at that area. They will accidentally do something. It might take 20 years, but they will do it. So we're just trying to become very efficient. But yes, I love grabbing the medial border. When you grab the medial border of a scapula, you help to stretch out rhomboids major and minor, at least the middle traps, if not other traps. You're hitting the subscapularis for sure. You're loosening up the insertions of the serratus anterior. So you're hitting 5 muscles at once. And that's assuming I don't go up a little bit further along that same medial border and hit the levator scapula. I realize we haven't learned about all these yet, but that's 6 muscles on one move, and that's why I like it. Yeah. When we go to the lateral border, we're hitting a whole bunch of other stuff. And we're talking about kind of attacking it from the front instead of the back. That's all. Well said. Okay. Let's go over a couple last little things. So these are good examples. When I do my normal effleurage, I do exactly what this guy's doing. I take my thumb and kind of run it through the supraspinatus fossa to get to the supraspinatus muscle. Here's the infraspinatus. Remember, on a real person, there'd be the teres minor right here. You'd hit both at the same time. This is like in the beginning, we tell you avoid bones, avoid bones, avoid bones. Now we're like, actually, we want you to massage the bones with finesse, right? So we want you to find the spine of the scapula and kind of work off the stuff up and below and above it. This is where you get some detail work in there. By the way, the supraspinatus is the one muscle that's not involved in rotation. It's a rotator cuff muscle that's not involved in rotation. I've said this one time and I'll say it 1,000 times. When I say infraspinatus, you say teres minor. They are synergists. They work together. They are partners. They are lifelong friends. By the way, multi-pennate fibers is not something you need to worry about. I suspect it's on tonight's test, so I threw it in there. It just means the fibers go out in these different directions like this. It's obvious to those of us looking at the picture, and they just gave it a name. Oh, here's a sideline picture. This is what I do, by the way. What this guy's doing right here, this is how I get to the subscapularis. I don't use my thumb, by the way. I use my fingers, but this is how I get to it. This is somebody doing it with somebody laying on their side. You're trying to create space underneath the scapula so you can get under there and play with it. Yeah. And when you guys go to lab today, you can be like, Mr. Ibarra, we learned about the rotator cuff muscles and we want to know how to get into the subscapularis. Give him a challenge. And he'll be like, tell him Tapscott told us to tell you that. Boom. And again, this is the supraspinatus. Notice how it runs under the acromion process. And I'll tell you a little massage trick that we're getting to, and I'll bring it up many, many times. But I really want you to think about this because we're dealing in three-dimensional reality in layers, okay? By the way, well, let's stop sharing for just a second. If I wanted to get into the supraspinatus insertion out here on the humerus, what muscle is in the way? Miss Rader, please.
The deltoid?
Good. Stay on, Miss Rader. I'm going to challenge you a little bit here. So, the deltoid is in the way. And believe it or not, everybody, the deltoid is actually elongated right now. It's in a stretch. So it's actually fairly taut right now. Right? Fairly taut, like this. If the client lifts it up, it's contracted. But if I lift it up for them, what happens to the deltoid? Ms. Rader, how does it feel now if you're not holding it up with this arm? It's just holding it, you've held it up for them.
Oh, so it's relaxed.
It is. It's relaxed in a position where it should be contracted so it's loose. Let me give you guys a different example of this. If I bring in my bicep, it's hard, right? But if the therapist brings in my arm, the bicep's loose. So if I was trying to get to a muscle below here, I'd actually want to put the bicep, this gets confusing, but it'll make sense. I put the bicep in a position where it would be contracted, but they're not contracting it, and I've got all this extra, looks like flab here, right? Because it's loose. We want to do the same thing with the deltoid. Lift up the arm for them. They can't help us. If they help us, they'll tighten up. Now the deltoid's loose, and I can push down through it and get to these insertions. Same thing with the trapezius. If I lift up their scapula, now if you guys do it right now, it'll be hard, but if I lift it up for them and it's soft, it's easier to get down into the supraspinatus. It's a trick for getting down through layers because we have other layers stopping us. Yeah? Mr. Overman, please.
So I'm just wondering if, with Miss Everson, I found when I bring her hands over the front of the table and let them hang there, and then go to palpate the supraspinatus, it works really well for her. Like,
yeah.
So
well,
is that
what?
because everything's loosening? Because it's flexed, but it's also just hanging. So is it?
Yeah. Here's what I think. So I know when you bring her arms over, you think there's a lot of action, and there is, by the way, there's a lot of action happening at the glenohumeral joint, right? But also when you bring my arms over the table like that, what happened to my scapulothoracic joint? It elevated. And elevation is what my trapezius does, but if my trapezius isn't doing that, it's loose. And my trapezius is what runs over the supraspinatus, over the supraspinous fossa.
So that's why it's working.
Yeah, and actually I never thought of that before in my life. So that's a great method for you to get into supraspinatus. Yeah, great observation. Yes, yes, yes. You did exactly what I'm talking about. Awesome. Ms. Carrillo, please.
Is it also because the muscles are shortened? Because I remember Mr. Ibarra was telling us yesterday, if the muscles are shortened, you can get really good deep tissue because they're all, I guess, together. Whereas versus lengthened, it'd be, will they be more spread out?
Yeah, I think he might be using shortened different than I would. I'm not disagreeing, actually. And I'm not trying to be...
I could be remembering wrong, too.
Yeah, but he's right. If they're in a position where they would be shortened, but they're not contracting, then they tend to be loose. It's very confusing, but I always use my bicep to cut because it's an easier thing to visualize. If I am contracting, my muscles are very short right here and very hard because I'm contracting. But if I'm not, if somebody else did it for me, they're just hanging down here loose. So in the position where they should be shortened, but they're not contracting, they didn't contract and they got all this extra space, right? You know? So I think him and I are saying the same thing, but differently. Yeah. And like you said, who knows how we remembered it and all that kind of stuff, but yeah. Ms. Hendrickson, please.
So, is it better to have it short just because, like, you can go over more muscle? Like,
yes and no. So,
because I'm thinking, like, if it was longer, wouldn't it be easier to get into the fibers? Like,
well, are we talking about getting into that particular muscle or getting through that muscle to another muscle?
just like say if you wanted the bicep, like.
So you're asking a really interesting question. She's asking, is it better to work the bicep or any muscle when it's lengthened and slightly tauter? Because my bicep is harder in this position than it is relaxed in this position. Right? Yeah. Super loose here.
Like longer and short, yeah.
Right. So there is actually an answer to this. It is kinder and gentler to work muscles when they're super loosey-goosey. This will hurt me less.
Oh, okay.
It is more painful and more effective to work them when they're in a stretch.
Okay.
And that's because it's all a stretch. So my favorite thing to do in massage, but I don't do it with everybody, let's say the client doesn't like deep pressure, things like that. But if I'm trying to really create change in your body, right? Why not, if I press on your back, I am stretching it out every place I press, right? When I press into something, I'm stretching it, but I'm only stretching it right there. Well, if I put your back in a stretch and then I press on you, I'm stretching you while you're in a stretch. I'm turbocharging your stretch, but it's more painful.
Okay.
And so this is very useful to know when you're really trying to create fascial change in somebody. You usually want to put them in a stretch and then work the area. Or when you have somebody who's psycho and they're like, I like really deep work and you're not going deep enough. It's like, okay, well let me lift your arm above your head before I work your lats and your triceps. Let me put your triceps in a stretch and strip them. Okay, that's deep enough. Yeah, I thought so. So it's helpful for that too, right? Or I get somebody who's like, oh, it's a little bit much. Okay, well, it's still a little bit much. Okay, well, let me put you in this really relaxed position and just squeeze stuff here. It's very gentle. Yeah, not as effective, but very gentle.
You would use it in different situations.
Yes. But dynamic change, there is nothing more powerful than massaging somebody while they are in a stretch. You are doing a micro stretch on a macro stretch. A macro stretch means a big stretch. I touch my toes and I'm stretching out my hamstrings and all sorts of stuff. And then you rub my hamstrings. Every place you're pushing is a micro stretch. Yeah. That's the best way to go. But it's not always appropriate. It's just not always appropriate at all. Most people, by the way, I think most of you are like this. Most of us want some therapy and some nice stuff, you know, right? Pleasure and pain together would be nice. I don't really want you to spend 2 hours stripping my fascia, and I don't want 2 hours of facial massage either. But it sure is nice when you include it with the other stuff. Ms. Dimitrik.
So is that like sports massage then when you're breaking up that fascia?
I no longer know. Here's what I mean by that. By the way, you're probably right. Here's the problem. Sports massage is actually technically a light, brisk massage, usually done through the clothing to usually warm up, or help flush out tissue. It's done right before an athletic event, sometimes right afterwards, sometimes even during. But definitely right before an athletic event, and you don't want to do deep tissue before an athletic event. That's what sports massage is. But the reason you think what you just thought, Ms. Dimitrik, is that all these other companies came along and said, we got to make our stuff look cooler. So I'll give you an example of the Princess, because we had sports massage at the Princess, and that was our deep tissue. So at the Princess, we didn't want to advertise Swedish massage, because Swedish massage is amazing, by the way. But in the States, people are like, oh, that's light, fluffy massage. So we call our Swedish massage therapeutic massage. All massage is therapeutic. I don't even understand what that term means. I mean, I know what it means. All massage is therapeutic, but we call our Swedish therapeutic. But we didn't want to call our deep tissue. It wasn't quite sexy enough. It's sports massage. Are you athletic? I bet you are. You need sports massage. So we no longer know what these terms mean anymore because people have marketed them. And I don't care, by the way. I don't take insult to that. I'm not like a purist, like, oh, you can't call it sports massage. I just don't know what they mean anymore. So people always ask me, what type of massage do you do? And I'm like, my massage. Like, I do my massage. I'll adjust it for your body. I do my massage. Like, I don't even know what the terms mean anymore. I really don't. Mr. Richards, please.
So within the course, when we joined the course, it gave you a description of different massages that you're going to learn in this course.
Yeah.
How do you differentiate between them?
All the long flowing strokes you're doing, effleurage, petrissage, compressions to Popman is Swedish massage. And as you guys, but the problem is the minute you start making those strokes deep, it starts to become deep tissue. And as you use less oils and lotions and go slower and deeper, it becomes myofascial work. So it's kind of like saying, how do you differentiate between Arizona and Colorado? When it starts getting green, you know you're in Colorado, but you don't know when it happened. So what I mean by that is the states are definitely different, but there's not a period where I'm immediately like, nope, that's no longer Swedish, we're now deep tissue. Because deep tissue is often effleurage done with my elbow. So I'm not trying to avoid the question, I'm just trying to say it's a tricky one to answer. But essentially, Swedish has long flowing strokes, things like that. It tends to be more superficial. It tends to get blood flow going. It tends to move skin around, get blood flow going. Deep tissue tends to get into the muscular tissue and actually start to separate fibers and stuff. Yeah. Oh, kitty time. Miss Abelos.
Yeah, so on athletes in general, you really, and this I might be wrong, but you don't do deep tissue very often because of muscle recovery on them. So it's like a light touch, like for example, I walk maybe 15 miles a day at my job. So people that do deep tissue on my legs, it's actually causing me to roll my ankles more and trip more because it's like weakening the muscles for me, but I need them to recover faster. So I would say do light massage work on my legs, or how does that work?
Actually, it works essentially the way you said. So Ms. Abelos points out a really interesting fact here. If you are working with an actual athlete, which by the way doesn't have to be a professional athlete, I meant somebody who's maybe walking 15 miles a day or whatever, the massage is supposed to match where they're at in their training cycle. So let's say it's off season and you're kind of training up and preparing for season, we might do lots of deep tissue. We're breaking down old scar tissue, we're getting stuff really healthy, we're helping you repair. But as you get closer and closer to the event, you're right, we switch to more effleurage. We don't want to break down your muscles. You're already putting them under a lot of stress. We want to just increase circulation in them. And by the time we get to the day of the event, it's just warm them up and go on, which is kind of what you're saying. It depends on where they're at and how much stuff is going on. But it's not that you never do deep tissue on an athlete. Some athletes you do lots of deep tissue on, but you're not breaking down their muscle at a time that they need their muscles to be at their peak, right? I'm not breaking down the bodybuilder's muscle a week before the event. I'm breaking down his muscle 3 months before the event when we're trying to build it all up and all that kind of stuff. As we get closer and closer, we tend to move that away. And so, Ms. Abelos, your personal experience might be like, they're getting enough right now, I need them just flushed out. Yeah, and that's legit. So it just really depends on where they're at in their training and what they ask you to do too. But the general rule of thumb, as they get closer to an event, you get more and more Swedishy. So, which kind of ties back into what you were talking about, Mr. Richards. That's when you start to cross back to like, I'm going to get circulation going. I'm actually going to go kind of fast. And I'm going to get blood going and I'm going to get you all red, right? Lots of redness and stuff like that, but I'm not going to dig. And digging starts to become deep tissue, yeah. And I'm sorry, by the way, it's all gray, right? It's all gray area, but you can kind of see where we shift from one to the other, yeah. Somebody else have their hand up? Miss Savarino, are you doing okay? Are you crashing from the coffee? Yeah, I saw you. She was like bouncing off the walls, and halfway through the thing, she kicks back. She goes, yeah. She's like, she's strung out. She's looking for more coffee in the house. She's like, what's going on? I'm like, get it together, man. What's going on with you? All right. Cool. Let's finish up here. Because we're basically done. I just want to make sure I didn't leave out anything. Boom. These... By the way, I'm not just saying this. These are the most intelligent questions I have ever had in a class ever since I've started teaching. Yeah, not yours, Mr. Richards, but everybody else's. You're the tutu guy. I don't even know what yeah. Okay. Mr.
Dan, what did you do to me? You making me say all this class?
She threw you under the bus. No, I love it. I love it. I love it. I love it. They're showing you ways to fill the...
Sorry. Sorry.
They're showing you some ways to access the supraspinatus. I don't like, by the way, accessing the supraspinatus the way it's shown in this move. Because look what's happening in the shoulder. It wants to come out of socket when you put somebody's arm behind their back. That's why police officers use this hold. They put your arm behind your back because your brain subconsciously knows if they keep lifting your arm, your shoulder will pop out in front. And your clients feel that way too. I know it's very common. Every massage school teaches it, and I occasionally use it. It's not a no-no. But if I can avoid putting their arm behind their back to get at their scapula or get whatever, I do. I really avoid it. I don't actually like that move. Just wanted to kind of show you that. Boom. And here they're showing you where you can find the insertion for the subscapularis. It's about 1 inch below. It's lateral from the coracoid process, about 1 inch below the acromion process. And it's actually between your two biceps brachii tendons. Okay. I'm reading my own notes here. Yeah. That's just some stuff. We've already talked about this stuff. My boss sent me this slide this morning. I love it. Throat punch Thursday when you can't wait for fist fight Friday. I don't know why. I just love a boss that sends me stuff like that. She's insane. Anyway. Okay, everybody. So, that's that.